Okay, I think we'll go ahead and get started. I apologize for the delay. I had some audio issues, and since I'm presenting, that would have been challenging. Um, my name is Lynne Keilman-Cruz. I'm the Deputy Director at Senior and Disability Services, for those of you that don't know me. And on the line with me, I have Jordan Grant. She's the Policy Unit Manager. And several of our policy team and our training team to help with navigation. And, when I get talking, I can't see the chat. I can't see what people are doing. So they'll cue me. I'm hoping they'll cue me anyways. So we'll go ahead and start. We like to start all of our presentations with our webinars with our mission statement. And I think it's really important to remind our stakeholders, our partners, and ourselves about why we are here, what we strive to achieve with the work we do every day, and who it is that we serve. Perhaps we don't always agree on the method to achieving our mission, but understanding what our purpose is may help us to identify common ground and allow each of us to keep an open mind through our discussions today. We'll provide opportunities to share with each other at the end. And my only ask is that we always keep this mission in mind, doing our best to stay positive, respectful, and solution-driven. The photos that you see here are actual people that we have the permission to use their photos. And it's just always a good reminder for us who it is we're here for. And then some of the other photos in the presentation are my own from a trip, just to keep you sort of entertained so you don't get bored with my presentation. And I am going to turn it over to Jordan for a little housekeeping.
Hello, I'm Jordan. I know many of us are familiar with Zoom or familiar with my little presentation on how we do housekeeping here, but just want to make sure we hit all the important information. So for Zoom, we just want to remind you that this webinar is being recorded, and we ask that you please do not share any private information, including names or health data, whether you're speaking it into the webinar or putting it in the chat. Please don't. Please don't. If you'd like to ask questions or comments during the question and answer period, we just ask that you raise your hand to request to be unmuted by the host, or you can ask your question into the chat. And just please remember that if you put something into the chat, it will be viewed by the entire audience. So just please, please, please no private information. You're also welcome always to email us at hss.dsds.policy@alaska.gov. You can always email us there with questions, suggestions, or even more specific situations that you wouldn't want to put into the chat today. And then finally, I know I said if you would like to have your mic unmuted, just please raise your hand. I just want to I know most people are familiar with Zoom, but at the bottom of the screen, there's a button called Reactions. So if you press that button, and I'm going to do it now so you can see, you can hit the raise hand button and lower hand button. And that is a great way to let us know you'd like to have your mic unmuted. And I think that's all I got. Thanks so much, Lynn.
Yeah, thank you, Jordan. And I didn't want to call Tony out, Anthony Newman as our director, unless I saw him in the meeting, because we just left another meeting. So Tony, thanks for coming. And I don't know if you wanted to say anything or.
Yeah, Lynn, I have a lot to say, but I will try and keep it brief. I wanted to thank you and thank everybody for joining. I thought I would just give a little bit of background on how we arrived at today's conversation. Lynn is going to go into the details on the changes we have proposed and are seeking to make permanent, and she'll provide those details. But just by a little bit of table setting, this is ultimately about complex needs people. That's people with disabilities who also have significant behavioral health or medical issues. It's been a population of people that the department has tried to serve better for a long time. In my years at SDS, we'd have these situations pop up now and then, often with youth who simply had nowhere to go, no one who could offer services for them. Parents might have tried everything, but say out of concern for safety of others in their home, They simply couldn't care for their son or their daughter anymore. And now they had to bring their child to API, and they were still there months later. Or maybe they were still in a juvenile facility, and even though there was really no justice-related reason for them to be there. Like I said, the department has always struggled with how to best care for these people, but it always seemed like we were able to muddle our way through to a solution when these cases would come up, thanks to good work by SDS staff and also by care coordinators and providers out there who put their shoulder to the wheel and would come up with answers for people. But something began to change earlier this year. It seemed like every few days, Lynne or my attention was being called to a complex case like the ones I've described, and the number of people who were in hospitals and unable to receive services seemed to be piling up. And whatever the reason for that was never quite apparent to me. It seemed that maybe it was due in part to the pandemic winding down. The expectations around how long people could be held in a hospital or other facility were relaxed during the pandemic, and now that the public health emergency was coming to a close, they needed to move on to more permanent settings. There also seemed to be more courts saying that due to a person's intellectual or developmental disability, they were not competent and could not be forced to stay at API or in a DJJ facility, and needed to find somewhere else to go. Whatever the reason, the situation was getting increasingly desperate and untenable, and the commissioner asked SDS to play a central role in helping and to take ownership of our own contribution to the challenges. We could be quick to say, well, the rules don't allow for, say, that group home service for that person, or for Acuity to be used that way. And clearly it became apparent that if the rules were getting in the way of us being able to do the right thing and to help people better, we needed to look at changing the rules. So I happened to go to a conference of SDS directors from around the country early in the summer, and I learned that we are not the only state that was struggling to come up with answers to these challenges. I also learned that CMS was interested in doing what it could to help states look at their challenges and find solutions. So fortunately, we still had the Appendix K amendment process that we could access and make changes to our waivers to better serve these individuals. And so that's what we did. Under a very short timeline, Lynne and her team created the specifics around how to make some of the rates and processes more flexible and practical. And I am profoundly grateful to you, Lynne, and to Jordan, and to all the others who helped do that work in a short time in the middle of the summer. So the efforts that Lynne's going to talk about aren't the only ones that the Department of Health and the new Department of Family and Community Services are working on. Perhaps you have heard of the Behavioral Health Roadmap, Crisis Now. These are initiatives. There are others that are underway to try and better serve people so they can avoid crisis placements, and the department can spend their money more wisely instead of on expensive hospital and emergency care. So I'm happy to talk about those with you if you'd like, but that's for another time. So I'm going to turn it back to you, Lynne. Thank you for letting me talk about that a little bit and how we arrived at today's webinar.
Thanks, Tony. Yeah, it fits right into what I was going to go over for our objectives for today, was to really explain the history, which Tony just did. I will go into a little more detail in describing the services and explain a little bit of the timing between what the Appendix K does and the new waiver amendments. Not new waivers, but just waiver amendments to our existing waivers. And we will review the process and timeline for the immediate changes that we've already made, and then what's to come in the future. And we'll give you an opportunity at the end. I'm going to try to speak fairly quickly, so it gives you opportunity to ask questions at the very end, since we started a little bit late today. So why are we here? So the Appendix K changes were a result, as Tony indicated, from our work together in the department level through what we call a case review team. And I'll go through that, the whole department sort of structure for that in a future slide. But you know, the whole goal, obviously, we all have the same goal, is to attempt to achieve better outcomes for the people that we serve. We we'll hopefully get to all of that today. So this is a little bit of the history of the department sort of structure. So when the department split last year, I guess it was, we decided we needed to have some kind of a procedural process or a way to still communicate between departments, because it's really important for the continuity of care. And so I think Dr. Zink is the one that sort of created this idea to come up with a case review team. And that case review team reviews cases that are really touch both departments perhaps and fall a little bit through the cracks as far as they have had failed placements or unsuccessful placements or escalating behaviors that are difficult to serve through regular processes, whatever, if it's through the other department or our department. And so we would review those cases and try to problem solve, as Tony talked about, and come up with ideas for how to fix those. And those often involve reaching out to care coordinators, reaching out to providers, and talking about, like, what are we going to do for this individual? If those things then come back and we go, wow, you know, there's a system change that needs to occur, some of those things would bump up to this complex care committee, which the department leadership is very invested in, as far as DFCS and DOH coming together. We have another one that's in person on December 11th to really talk about what is it that needs to change or what things can we try. And then the other part of that is the Complex Care Steering Committee, which hasn't really occurred yet, hasn't happened yet. But the hope is that anything that we, you know, maybe we try something, it doesn't work, or we need something else, we would take that out to a Complex Care Committee, which will involve some providers as well. And it's a broader group to help sort of steer where we're headed with any of our complex care work. So where we're at really mostly now is in the Complex Care Committee, and we're still working through some of the things. And that's what the work, that's really what helped us to come up with these new types of services. So what are the new services in AppK? I'll just go through these really quickly. We added a specialized family home habilitation under specific conditions, a specialized group home habilitation under specific conditions. We added ages 16 and older could be served in a group home under specific conditions. So that's not every 16-year-old can then suddenly be served in a group home. Those have to require a very specific set of circumstances. We also added that Acuity would be available in those specialized homes, but also added that it would be available in family home habilitation, which we have never done before. But again, it would be sort of the same way we do group home Acuity add-on currently, but we're hoping that some of the ways that we get there are more transparent to you. We're trying to create criteria that is available publicly for you to review. We added, instead of having a 24-hour Acuity like we currently have, we added 8-hour blocks of Acuity. So our normal 1-to-1 24-hour Acuity is going away, and we added a 1-to-1 Acuity of 8 hours. It doesn't mean that the criteria to get Acuity is easier or simpler. It just means that we're adding flexibility into those services. And I'll try to explain that a little bit more in another slide. We also added a 2-to-1 Acuity, again, in 8-hour blocks, and those require specific conditions as well. So the 2-to-1 Acuity, very high bar, not gonna lie. And those require some specific conditions. We're really going to focus on the Acuity today. I'm not really going to talk about specialized FamHab, specialized group homes. I just brought that up because I wanted you to know what goes into the AppK, or what went into our most recent Appendix K. So let me back up for a second. I did want to talk a little bit about the fact that Appendix K itself is really appending our current base waivers. And we can do that through a pandemic or a disaster. So we did it in the earthquake in 2018. We did it in some fires. We did it for COVID. And we had many versions of those appendixes that went into CMS, the Centers for Medicare and Medicaid. So that's our ability to ask for flexibilities from the federal government in how we apply our waivers. And so in an emergency, we could change some things, which you all saw during COVID, which was the biggest APK we've ever filed. So this particular one went in where we asked for these services, and it was approved, I think early October. Don't quote me on that. I can't remember the exact date, but it got approved. So what that means, though, is that those services are not just like widely available necessarily. They're approved on a case-by-case basis under Appendix K. And the reason we do that is because we have to carefully roll that out, because we actually don't have regulations for this specialized family hab home, specialized group home. We haven't changed or amended our regulations. And at this point, we've only proposed to change our base waivers to include all of these services in it. So once those waivers are amended, they'll have an effective date at some point in the future. At that point, regulations will be created to stand those services up permanently. So that's one of the reasons we feel very good and able to come out and speak to all of you and get your feedback on this today, because we're able to, we're not in a regulatory writing session yet. We're just getting geared up. So we sort of did some webinars. We talked about what was going to go into our amendments of, I don't know, I guess that was in October. We filed those amendments. We have some back and forth that we need to do with CMS. And so those permanent services won't go forward until those are all approved and we have regulations to go in it. However, under Appendix K, we can approve some of these services under our Appendix K because we have that authority. So it makes it very confusing for timelines. But we have to do this by a case-by-case basis. So if people wanted to become a family home, specialized family home hab, we could stand that up with the things that we have written into our Appendix K. But again, it is going to be on a very limited basis. So Acuity add-on is what we're really talking about today. And one of the things I wanted to keep pointing out, is that we will allow it in the specialized homes. We'll allow it in addition to the standard group home service that was already there, and in family home habilitation, which we haven't done before. The 24-hour one-to-one acuity was retired. So I know it's kind of a shock to care coordinators. We tried to get phone calls out to billers and to folks to say, if you had a person, we had about, I think, I don't know, over 20 people, 25, 27, something like that, that have a one-to-one acuity. We removed the one-to-one acuity rate, which I'll show you in a minute, and we added 3 8-hour segments, 8-hour blocks. One of the reasons that we really went into those 8-hour blocks is that under our original Appendix K, where we thought of these ideas, we had 12-hour blocks. We had 2 12-hour blocks. We went out, we talked to people about it, and we heard from providers loud and clear, you know, those 12 hours, that's a great idea, but it's not the greatest idea. The greatest idea would be to break it into 8-hour blocks, which is how we staff our homes. So that would make more sense to have 3 8-hour blocks and make it more flexible. And, you know, one of the assumptions that, you know, erroneously I had was that when someone got a 24-hour acuity, hardly any providers ever stepped that down. And what I found after talking to providers is that that's not really true. They just didn't bill us for it. They often step it down, but don't bill us for it. And so, we came back, we talked to our team here and said, what would be the best, easiest, most flexible way for a provider to be able to step it back and give people more and more independence with Acuity in place? Because the whole point of Acuity is to keep people safe. But if we don't step that back ever and allow them autonomy and independence without a one-to-one person on them, it's not really fair to the individual. And I know providers really want to build autonomy and independence. And so that's one of the reasons we walked it back, said, how about we'll start here with one-to-one Acuity add-on, 8 hours in 8-hour increments. We also added 2-to-1, as I mentioned before, per 8 hours. And so that rate is going to be in the system. These cases for 2-to-1, like I said, that would be a very rare occurrence, should be, and those will be routed through our case review team. So I'll walk through that in just a second about how we think the process will work for that. And then the other thing I talked about is we really want that review criteria to be more transparent to providers and care coordinators, especially for knowing what it is we're looking for to be able to authorize that Acuity, and then what kind of documentation would we need to support it. So here's sort of some of the example of the criteria that we came up with. This, of course, again, we haven't written anything in regulation yet. This is sort of something for us to ponder. And so these are the things that we would really like feedback on. And I can get these slides out to you. I see people taking notes, and I will definitely make sure that we have these slides available to pass out to you. But one of the things we talked about is that Acuity is really a service performed by a dedicated staff, and it's really assigned to the participant within Sight and Sound. And we've talked about that. We really need to define what Sight and Sound is. We've had providers ask, can they just be on a video monitor? Could I be outside and have them on a video monitor? Well, no, that's not Sight and Sound. And so that's really sort of something that we feel like we need to define for folks. And it really is for the prevention of either assault, self-injury, destruction of property, sexualized behaviors that put themselves or others at risk, severe elopement, or injury or death due to a medical emergency. So we're trying to prevent those things from happening for the individual. And it has to allow the person to reside safely in the community. So this isn't just for individuals that might need a little bit of help. We would expect that from the normal service. These are individuals that have a higher need to keep them safe in the community. So the other thing we felt like, would video monitoring, when we're talking about Sight and Sound, would that just be completely off the table? And I don't think it would be, because again, as we were talking about it internally, what would be therapeutic, sometimes it is to ease out of the service. And one way might be to be able to provide some video monitoring where you could easily get to the person if there was an issue, but it allows people to sort of build autonomy. Again, we're always thinking about how do you build that independence and autonomy. And then of course, if it's a dedicated staff overnight, they'd have to be awake. One of the issues I think we've had is that I heard from providers, like I could have provided under the 1-to-1 24-hour block, it was too stringent. So I could have provided 16 hours of staffing, and then I didn't have a staff show up in the night shift, but the person's sleeping, but I can't bill for the service because I only provided 16 of the hours. So this allows for a little bit more flexibility. The other part that we heard from folks is that 24-hour bar was really hard because sometimes people did sleep through the night and their behaviors were all during the day. And so staffing those extra 8 hours didn't make sense. So we're really hoping that this will sort of meet a little bit more of the mark. But again, would love to hear everybody's comments on this. This is really important to us for building out regulations. So the case review team referrals. So in the cases of the 2-to-1 staffing, we have had individuals that were provided 2-to-1. They were paid from general fund or from another department. And then we paid the 1-to-1 acuity. And even those individuals had difficulty being supported in the community. That's where we really felt like for a specialized home, they should still be able to get a 1-to-1 or a 2-to-1 acuity if that's what's needed to really keep people safe in their home. So what would happen is the care coordinator would work with the planning team, just like you always do, to gather the required documentation supporting that level of need. You'd submit it to SDS, and then SDS review staff reviews it, asks for any remaining documentation they need to make the case, and then they would make a recommendation. Again, this is for the 2-to-1. Or another case of this is for the 16-year-old to go into the group home. Those also will have to go through the case review. So we would also have to approve that ahead of time. Nobody can be placed into a group home when they're 16 years old unless they have a licensing variance and SDS has already approved it and it's gone through the CRT. So I want to be very clear about that. 16 years old is young. We were able to get this through with CMS because we said, 1, we're going to do it in a case-by-case scenario. 2, we felt like at 16, your body's more developed and you're more adult-like than childlike, regardless of your functional level. But also, it's really important that there'll be some things that we're going to ask for, a safety plan for one, of how you're going to keep a child safe in an adult home. So there are other things that will have to go into play for those to be approved. So the case review team referrals, once licensing has had a time to deny or approve the variance, if there is a variance application applicable in the case, and then we would get it. We give it out to the CRT. The CRT meets every week. And so we would either get approved or deny recommendations, but SDS makes the final decision. And again, those are for 2-to-1 acuity, for the 16-year-old in a group home, and for those specialized home placements. These are the codes, the new codes. And again, these will come out to you. So the retired code is the T2016 TG, and the new codes are, as you see here. And we have to put those in the system. And for specialized homes, the provider has to actually meet a credential to even have that available to be placed on a plan. So that's a different step. We'll go into more of that, at a different time. Today, we just really wanted to talk about those acuities, and these are the codes for the acuities and those specialized homes. And does anybody have questions? Or I can't see the chat. I'm not sure how much, if anybody has put anything into the chat. If you would like to be unmuted and talk, be happy to hear from you.
We definitely would love to hear any comments, suggestions, questions. Just before we get started on any question and answer, I just want to make a pitch that the recording will be available on the policy YouTube channel. So if you feel like that was a lot of info and I didn't get it all at once, just know that recording will be available to you. And also, if you'd like a copy of the slides, can you please send us an email to the policy email box, and we'd be happy to send you a PDF of the slides, no problem. And finally, taking questions and comments, and just to set expectations, we are still kind of figuring this out. So we may not be able to specifically answer every question right now, but it does help us to hear the questions so we can know what we need to consider as we're working through this. What kinds of questions are coming up, what kinds of thoughts people have, or your really great ideas. We really would love to hear it. So I do believe we have.
I have one question in the chat
Yeah.
that I can answer that helps.
Okay.
Thank you for asking it, Kim. So her question is, are the rates for these acuity units determined? Sorry if I missed that. So under Appendix K, that's what we have the rates approved for. So only under Appendix K. So as we're building out these requirements and we're pushing it through the amendment to CMS and we're building out regulations, we also have to work with Office of Rate Review to determine if those rates are okay. But to make sure that folks understand, we did this super fast, but how we did it was we took the 24-hour block and we divided it into 3 increments to make 8-hour blocks. So we're not really establishing a new rate. We're just cutting it in thirds to give an 8-hour rate. And then for the 2-to-1, all we did was double it. Same thing, broke it into 3, doubled. And we have the approval for that under the Appendix K, but we do not have any going forward from that yet.
Thank you so much, Lynn. And we do have a hand up. Megan, are you able to unmute yourself?
Yes, thank you. I have 2 questions. The first is just a clarifying question. So the specialized homes are at a different rate, and then the acuity would be at an add-on to a group home. And so the acuity would not be added on to the specialized homes?
No, it would be available. So the acuity isn't added on to the home itself. The acuity is added on to the person's plan. So if, for instance, Jordan had a specialized home and she was serving Tony, and Tony presented with enough need that he needed a 1-to-1 acuity or 2-to-1 acuity, we could authorize that even though he's in a specialized home. So that specialized home will have more staff. It'll hopefully have more specialized staff, but it's still, he may need that level of support. Those are the things we would consider, so it would still be available to him. Did that answer your question, Megan?
Yes, thank you.
Great.
And then my second question is, as care coordinators, we are quite ahead of plans. What if we've already submitted an acuity request based on the daily rate? What's guidance for that?
Good question. So that's what I meant. We went into we went in on November 30th and we pulled all the people that had existing acuities and we backed out their service authorization for that one code and we added 3 units to that code. And so anything coming in from here forward, our reviewers would know to enter the 3 codes and service authorize 3 units of that instead of 1 of the old code. And sorry, just for the timing, we had hoped to have this all done before we actually did it, made the changes, but healthcare services was surprisingly very, very good for us. They did it pretty fast in the whole big scope of thing. I'm saying it's a surprise because sometimes it's a lot of work to get systems change done. So they did a great job of getting it to us by December 1st. So we just said, we'll just roll with it and we'll get people information as soon as we possibly can. And we did try to call some people and let them know that, but.
Yeah, and Lynn, this is Tony. Just to you and Jordan and the others in the SCS team also deserve credit for doing what you could to prep SDS. We had preliminary conversations with them to share with them what we wanted to do. We got good feedback from technical assistants like Mary Sowers at the NASDBS, NASDs, are one of our support organizations. I think Megan, you asked a question though, whether this only applies to group home, and we do under Appendix K. We did add it for family home habilitation as well. So I didn't want to get glossed over. The ability for acuity under certain conditions, like Lynn said.
Mhm.
And then just to popcorn back over to the chat, we do have a couple of questions in there, and then we'll come back to folks who'd like to have their microphones unmuted. So next question we have is about case review team services. Someone is wondering what the ages are that would be going to case review this year.
Well, it really depends. So it's not really for the age of the people going to case review, anybody we serve, but if they needed a 2-to-1 acuity, or they were 16 or 17-year-old, and someone is requesting that they go to a group home because they cannot find another setting, that's going to be really important. Our whole goal is to keep children with children and adults with adults. So this should be a one-off. It should not happen very often. Those will have to go through the case review team. And then anybody, so we could serve in family home habilitation. You could serve any age of child, 0 to, 17, 18. Those would all, if it was a specialized home, those would all go through case review. And then of course, adults all the way up till, the end of life.
Thank you, Lynn. And then we do have another hand up. So Amanda, if you'd like to unmute your microphone.
Sure, I can just read my question. Typically with these complex cases, they're in an institutional setting, and we're kind of trying to determine if we can meet their need, and acuity is sometimes a big part of that. What kind of documentation are you thinking needs to be provided to get the acuity? And because they're in an institution, so you just assume that it would naturally come. Right now, the process to get acuity for a provider is really tough if we've never met the person. So in the past, when I've transitioned from someone from an institution, I had to read notes and notes and notes for weeks. And I just filled out this log of every 15 minutes because they were in an institution and not with us. What type of, were you still thinking the same 15-minute log process? And if so, I agree with the person before. Providers need training on how to do that documentation. It takes hours.
Yeah, it is difficult, honestly, Amanda, for us to make the decision. And we've had this discussion internally. I'll just share, because lots of times the baseline at an institution is a lot different than it's going to look for a provider in the community. Mm-hmm. So those are the things that we are trying to add sort of into our own purview, I will say, for what we might consider. But when it comes right down to it, having some documentation, hard, cold documentation that's written that says the person needs an acuity based on they've experienced these behaviors, even at the institution. They required a 1-to-1 staff, they required PRN meds, they had 5 episodes in a week, something like that. We have to have something. So I think we're going to work more with our reviewers on hopefully being able to talk about what that is. If you have suggestions for how
my suggestion would be to take all the case notes, because typically you can get 6 months of case notes for someone institution. Mm-hmm. And I can just submit that with the plan and say, would they meet acuity, and let reviewers kind of tease through that, because I feel like the documentation is there, but we almost have to pre-digest it and then put it on this special form. And I think it's the form that kind of gets me.
Yeah, gotcha. I would have to talk to our reviewers about that to find out, because what we've also gotten in the past is people that send us, a case of documentation and say, here, you do it. And we don't have time for that either. So it sort of has to be a happy medium between all of us, I think, to figure out if the person truly measures up. And I know a lot of people think, well, they're coming from an institution, they have to meet acuity, but that's not always true. And so those are the things that we're sort of considering as we go forward. And would they need 1-to-1? Do they need 2-to-1? I mean, those are things we have to have more thought on. But
thank you, Lynn. And just to popcorn back to the chat for a minute, I think we mentioned it very briefly in in that last comment, but there's a request for more training on acuity for care coordinators and providers who have found that providers often don't know the steps and level of documentation required for acuity. And I think part of this conversation is that we are looking to make it really clear what is required for acuity. And so hopefully we can develop some trainings that will be able to communicate that to providers, make it a really clear benchmark. And then we do have another hand up. Kim, would you like to unmute yourself?
Yeah, it's along the same topic. I just kind of wanted to add on. I actually had somebody text me during the webinar about documentation for acuity and the administrative burden. And I wonder what other states do. Like, I wonder if we can think about it in some different way, because I hear what you guys are saying. Of course, you have to be clear yourselves on what justifies this higher level so that you can differentiate. And it takes away from direct care. It takes away from, you know, the focus on the person, because the documentation is so burdensome. And sometimes because of a provider's lack of ability to document, the individual doesn't get the care because they just don't have the systems in place. I just wonder if that's an area, understanding there's like the immediate need to get things going, and then let's build it. And if there's even, is there technology we could look at? I'm just trying to think, like, that piece seems like, could we be better at that? And I wanted to just plant that seed. So thanks for the opportunity to share that thought.
Thanks, Kim. I know we have looked at other systems, and some other states, they approve acuity based on the assessment. And we have varying assessments, right? So our hope is this is temporary, and that at some point in the future, if we move to Interi, we would have a much more an easier way for us to flag or set some algorithms that would say this person qualifies for acuity. And that is unfortunately not a quick answer. But I do think that, you know, we have looked at some other systems, because not only is it administratively burdensome for you, it is a big ask for us, and it's a lot of pressure for us. And we get a lot of pressure to give acuities, but then we also feel like, you know, sometimes we, you know, it's a lot of work for us to comb through documentation and review that. So we definitely understand how hard it is, but we also feel like we have to pass that red face test to say we've looked at it and this person does qualify, this person doesn't, and we have to have a pretty clear idea of why. And that's where we've done a lot of internal like review of our own processes and thought on it as well, and hopefully we're going to sort of meld in the middle for a little while until we have a better system. And, you know, we also, one thing I would like to say is that, you know, we've known for a while that the 1-to-1 24-hour acuity was not flexible enough. It was, you know, in the old system, people could request 4 hours in an afternoon, but they had to provide documentation for that. It would come to me. I was the program manager at the time. I'd have to review it and determine if it was yes or a no. It's a lot of like ambiguity that was. So we tried to make it very clean in regs, and then we made it too stringent. So this is just a way to sort of ease it back, make it a little more flexible as we think about how we could do it in an even more thoughtful process in the future. But under the guise of we had to do it super fast, we can't make a ton of changes to it yet. And we're trying to get a whole bunch of work done all at once. That's why we sort of just said, let's do this and see if we can at least make a forward progress.
And yeah, I just was going to add, this is the time to get feedback like that, and we do have the time to do some research as to what other states are doing, Kim, because soon we'll be entering into the regs development process where we'll have that stuff available in regulation for everybody to be able to access. So thanks for that.
Mm-hmm. Yeah, and you know, I would say again, we're always interested if you know of states that do it differently and they are not using their assessment to do it, because we're not going to switch assessment now to a different thing. But if you know of a way they do it, the hard part about looking at other states sometimes is that we're all set up so differently. It's really difficult to take, you know, A and compare it to A over here. but we're happy to review it. If you guys have ideas, we'd love to hear them.
And please send those ideas to the policy email box. We'd love to hear suggestions, ideas. Have you thought about this? What about this? This is a real pain point. All of those things really help us as we move through and think through all of this. And on that same topic, I just want to say in the chat, we do have quite a lot of comments that are on the kind of on the theme of documentation and kind of the burden of documentation, how it can be cumbersome for care coordinators and for providers. And so I think that is definitely something that we're going to have to consider more. There seems to be a lot of energy around that. So I appreciate everyone who's put comments like that into the chat. We're certainly going to take all of that into consideration. We do have also some support for acuity based on assessment.
Mm-hmm.
And then we do have, oh, go ahead, Lynn.
All right, there is a question about whether we would do a pay increment for people submitting acuities. At this time, we don't have the authority or the ability to do that. It may be something that we could think about in the future, but this time we don't have that. And then the training requests, I think that's part of why we're having this dialogue. We'd love to hear from people, and we can kind of work through and figure out how we would train to it for what the final thing that we do come up with. Yeah, again, same thing you said. Megan had a question about billing, whether if they're in 8-hour segments, they would have to have supportive notes for those 8 hours of acuity. Technically, yes, but you would for a 24-hour acuity the same, I would think. So I don't think it'll change all that much.
I guess I was referring to around staffing wise, thinking on the provider side. Typically, if it's a 24-hour acuity, you have 2 shifts, 12 hours, and then you're looking at this person now has been approved for 3 8-hour shifts, or I'm sorry, 3-hour blocks. How it's, again, looking at that burden on the documentation. Now we're looking at 3 8-hour notes. Just putting that out there.
Mm-hmm. Technically, if you had 3 different people though doing the service, you would probably expect to see, even if you had 2 different people doing the 12-hour shifts, you would expect to see those notes from 2 different people. So I think, it kind of goes with providing the service that you would provide a note.
Do we
Great
have any?
questions.
Yeah, really, really helpful. Do we have anyone else who would like to have their microphone unmuted and share any suggestions or questions that they might have? Our chat has slowed down a little bit, so feel free to also put any last minute questions in there. I know for many of us were attending this over the lunch hour, so we are more than happy to let people go 5 minutes early if we've reached the end of questions. And that doesn't necessarily mean that's the end of your time to comment. We'd still love to hear from you, either an email to the policy box, which you can see in the chat. We've included the email there, and then this recording will be online. If you want to just take some time to rewatch or think about it, we would love to hear comments, suggestions, questions, current frustrations.
It is very helpful for us to hear from folks. And I think, based on the feedback we've already gotten is how we changed it from 2 12-hour units to 3 8-hour units. It's just so helpful to hear from people that actually have to deliver the service and figure out how to make it all work. So we appreciate you.
Well, Lynn, seeing as we've reached a slowdown in questions, both with hands raised and in the chat, I think we'd be okay to conclude for today. Thank you so much to Lynn for presenting, and Tony for joining us, and for everyone for joining us today to talk about Acuity. We really appreciate it.
Thank you. Thanks, everyone.
Thanks. Have a good day.
Thanks, everyone. Good job, Lynn.
Yep. Thanks. Bye-bye.